it's for everybody, because what happens that you can come across this scenario in your life somewhere. Okay, so how did we manage this patient? And I think we need an input from your side as well. So I will say that this will be an interactive session, and please don't hesitate to say something. Okay, hopefully we all will learn something. And I hand over to Dr. Mushtaq.
Bismillahirrahmanirrahim. I am Dr. Mushtaq Ahmad, Senior Medical Officer, Pediatric Medicine. A baby boy, 2500 gram, born in 36 plus 4 weeks, gestation, at the gestation, to a mother, 34 years old woman. She was gravida 2 para 1. She has uncomplicated pregnancy. Baby delivered by C-section. The reason for C-section was previous one C-section and labor pain. Immediately after birth, baby was well, immediate cry. APGAR score at the 1 minute was 8 and at 5 minutes was 9. Baby was okay after birth and shifted to the nursery for routine care. Oral feed started after checking the vital signs and baby overall condition. At the age of 16 hours, baby developed respiratory difficulty, recession, grunting and cyanosis. Vital sign recorded at this movement: pulse rate 150 per minute, respiratory rate 62 per minute, saturation 80% in the room airs, and immediately oxygen attached with nasal prong, but saturation did not improve significantly and was in mid 80s but less than 90. The difference between periductal and postductal saturation was less than 3%. Other examination, there was decreased air entry on the right side, and baby has very good femoral pulses, no cardiac murmur appreciated, and there was no hepatomegaly, and overall perfusion was good. Based on these findings, what could be the possibilities? As the baby was well after birth and 16-hour duration, condition was well. At the 16th hour, these findings were appreciated, and baby is not responding well to the oxygen supplementation. Yes.
Especially when the air entry is decreased on one side, you can always take it over. Coronary could be a possibility. Right? Okay. But just remember one thing with the coronary when the mouth is closed, they just do. Okay. This is our normal protocol. You see, it's very good. Every baby presents with cyanosis after we always do saturations. When we give them, if the saturations are not improving, we give them oxygen and we do the pre and post saturation. Okay, just to make sure that we're not losing the heart. Okay, and he actually mentioned one thing which is very significant, that the difference between pre-ductal and post-ductal saturation was only 3%. It doesn't go in favor of oxygen. Okay, pre-ductal is right and post-ductal is left. Right? So this is the situation now. So anyway, what we did next is it was a Saturday morning, early morning, around 8 o'clock I think.
Yes.
So we did a chest X-ray. Okay.
This was the chest X-ray.
Any comments on the chest X-ray? Anything else? Yes. Good. Okay. we look at the X-ray, we see that the clavicles they are at the same distance and no rotation. Okay, but if we look at the right side, there's a line coming there. Okay, and the heart is being pushed right to the left. Okay, so we presume that this could be an area. Okay, and otherwise we can say that there is a heart to the right side. And the liver is going down. Look at the liver, right down.
So this is the X-ray. What could be the, on the basis of this, there is a right-sided pneumothorax, and this is basically tension pneumothorax. Mediastinum is shifting toward the left side, and the diaphragm is going down, and baby clinical condition is deteriorating. He is not responding to the oxygen supplementation. So the next step is needle aspiration.
And the very interesting thing is that there was no resuscitation done on this baby as well. No handling was done. And still the baby got the pneumothorax. Okay, so spontaneous tension pneumothorax. Okay, so the next step is don't worry too much. Okay, just take a butterfly needle. Butterfly. Okay, and fill a syringe with a little of water and stick into the left segment process. You buy a butterfly because it's small needle, it will go in deep. So what you can do is you start aspirating. The water will show you the bubbles. Okay, so this is what we did, and when we did this, the saturation they started to and they came out to like this. Okay.
After needle aspiration, saturation improved 96%. After some time, saturation dropped again. So decided to chest intubation. Basically, after evacuating the air, usually the patient improve, and pneumothorax in the neonates usually require no treatment. So resolve spontaneously, and sometimes needle aspiration needed, and rarely we do chest intubation. After the needle aspiration, the baby deteriorated again, so decided to chest intubation in this patient. After chest intubation, initial oxygen saturation improved, but the baby worsening respiratory distress and again desaturated afterward. So next step was adjust the chest tube, air column movement and bubbling ensured before proceeding. Next, after repeat chest X-ray, there was massive pneumothorax again. So usually the response should be there after chest intubation. The pneumothorax should be resolved and baby condition should be improved. But after chest intubation and functioning of the chest intubation was normal, again there was massive pneumothorax persistent in this patient. So here we do the active section.
It's an interesting thing that normally pneumothorax for your baby is moved with needle aspiration. Okay, small pneumothorax, you do nothing after aspiration, leave them alone for 150 oxygen, and then you see very good. Okay, but unfortunately in this situation, the pneumothorax was not improving without the tube. So what we did is that a very bad thing to tell somebody outside that okay, there is no problem chest rate for the baby. So what we did, it's a funny drain, we put it in the chest, but the baby was still deteriorating. So what we had to do is that we had to take and and inserted that in the chest. So that's the situation.
So at this moment we done active section through the attitude tube, and during this whole process baby overall condition was deteriorated and baby exhausted during respiration. Also we decided to ventilate the patient and attach the active section through the chest tube. Initial ventilator setting was on minimum pressure 20/5, FI to 90%, and after attaching the active section through the chest tube, the patient clinical condition improved, saturation improved, and circulation improved. The initial blood gas before the intubation, there was retention of carbon dioxide and acidosis. After that, there was improvement in the carbon dioxide and acidosis improved. Further septic workup was done, CRP and blood culture sent and turned out negative. On CBC, there was normal CBC and not significant in that. Echocardiography also done to rule out the cyanotic congenital heart disease in this patient, but turned out moderate PDA, that is acyanotic heart disease, and don't go into the cyanosis usually. There was also mild pulmonary hypertension in this patient. This cardiac disease was treated with restricted fluid only, no medication was given. Other significant things appreciated, hypocalcemia and hyperbilirubinemia, that was managed accordingly with phototherapy and calcium supplement. Baby remained on ventilator for 4 to 5 days, and during whole process, these were the X-rays. Initial days X-ray, there is persistent pneumothorax, and later on there is expansion of lung volume, and there is last X-ray. Lung volume expanded, lung expanded. Left side, there is collapse. No.
You see, the heart is being pushed. I agree with you what you're saying. Actually, the heart is being pushed. You see, the problem is that we had a lot of problems because we inserted the HET and there were no proper connections. There was no proper underwater seat. So we had to apply, normally in babies we don't apply negative pressure. In my experience, I think I've never come across negative pressure. First time in my experience, it's first time we have to apply negative pressure. And the other thing is that this baby actually can need ventilation, but unfortunately we had to ventilate because the baby was not improved. So saturations they were going down to 60s and blood pressure was going down very okay, and eventually it was fine.
In this situation, can we try the 2-lung ventilation with the tubes? Ventilate the lung separately?
We tried. We tried and we actually put 2 ECTs, we joined them together and we inserted them, and baby was improving but still desaturating, so then we had to intubate the baby. So then we pulled out one and we left the other one only, and you can see that the baby improved after 3 days.
So sir, do we do I don't know what the name of the procedure is, fluororesis? Do we do that?
Needless
Would you have considered that if the baby is not moving?
Yes, we can, but I think at this stage it was not needed because we are still in the acute stage. Okay, if the baby is not improving for a while, then eventually I think you have to ask the thoracic people that look, and I phoned them and I discussed the X-rays and everything with them. So they said that you are doing very well, but if you are stuck somewhere, we will definitely help you.
So कौन सी सर्विस करती है सर्जरी?
सर्जरी हमारे यहाँ तो हम किसी को नहीं कहते कि हमारे लिए चेस्ट ड्रेन डालें. We do ourselves. We don't even ask the pediatric surgeons. I'm sorry, please don't get offended. Because this is our job. Okay, but if we are stuck, obviously we have to ask somebody. And we were just stuck because of the tube. Because we didn't have the proper tube, but we improvised the tube, and fortunately this is the second patient we had to do this thing. And I have ordered some chest drains and they have come fortunately, and hopefully we won't have a problem next time.
Okay. So when the chest tube was initially placed, what was it attached to? Was it attached to underwater?
Initially we put it, we improvised everything. What happens that the connections were not proper, we took the giving set for the IV line, and we inserted it into a small bottle. Okay, but when the baby was not improving, we had to do negative suction. Okay, and
But the negative suction rather than directly?
no. Negative suction was attached to a proper, the whole device. Okay, so we want to see. So we had to do that.
They will remain on the ventilator for 4 days and negative suction for chest pain for 5 days, gradually wean off from ventilator and negative suction machine when clinical condition and chest radiograph improved. After that, CT scan chest was done. There was cystic lesion in the right upper lobe, not communicating with the main bronchus.
We did the CT chest to rule out if there was any congenital abnormality, okay, like CTAM or something like this. So what happens that we couldn't find anything except these one or two small pockets. You can see the black shadows. This one, this is some crap here. So hopefully it will go.
Pneumothorax is the collection of ears in the pleural cavity between viscera and parietal pleura. So important things to note initially is whether is the detention pneumothorax or not. Is the patient symptomatic or asymptomatic? Whether the patient is on ventilator or on room air, any other risk factor are present or not. Because the decision to treat this pneumothorax is based on these findings. Initially, we have to decide whether these things are present or not. Grossly, we divide the cause of the pneumothorax is usually idiopathic. No underlying lung pathology is found in patient. The secondary causes may be there. In the secondary causes, respiratory distress syndrome, meconium aspiration syndrome, these are causative agent for the pneumothorax. And other thing is positive pressure ventilation can lead to the pneumothorax. In the tension pneumothorax, there is air goes in the pleural cavity during inspiration and did not come out during expiration. It acts as a one-way valve. Because air is trapped, the intrathoracic pressure is increases. These all things lead to the cardiopulmonary arrest, cardiopulmonary compromise. This is very dangerous. The base of clinical presentation is RDS, cyanotic congenital heart disease, congenital diaphragmatic hernia, and congenital cystic adrenal malformation, European. Based on the radiological finding on the chest X-ray, these can be the differential diagnosis: pneumomediastinum, congenital lumbar emphysema, atelectasis with compensatory hyperinflation, diaphragmatic hernia, and congenital cystic adrenal malformation with large pulmonary cyst. Investigation on the bedside transillumination test can be performed, and that is easy to do, and no technician is required. Second one is chest X-ray. We can easily find the pneumothorax on chest X-ray, and ultrasound has a very good sensitivity and specificity, but it is technician dependent. We need radiologist for this. Treatment is initially first line is the thoracocentesis or needle aspiration. Cannula is inserted in the pleural space to release the air, allowing the lung to reinflate. Because pneumothorax is life-threatening for newborn, immediately removal of the air from the pleural space is very important. This procedure carries risk for damage to the lungs, pleura with the needle track as the lung reinflate. Only can be performed by specifically 10 persons. Usually done at the second intercostal space. Next is the chest intubation. Chest tube placed in fourth intercostal space or fifth intercostal space in mid-axillary line. In case of non-tension pneumothorax, usually occurs in 1 to 2% newborns. No treatment is required, only observation is needed, and sometimes oxygen supplementation that lead to improvement in the pneumothorax. Majority of patients will need only the needle aspiration and sometimes need chest intubation in case of non-tension pneumothorax. Persistent pneumothorax, rarely it can persist more than 7 days in the absence of the lung problem. Sometimes who have chest tube, still air leak that persists for more than 1 week. Persistent pneumothorax can be treated with the high frequency ventilation, unilateral lung intubation. Implication for nursing that most important nursing function in caring for infants susceptible to pneumothorax is close vigilance. Be alert for the pneumothorax. These are high risk patients that can lead to the pneumothorax. Infants with RDS, respiratory distress syndrome, with or without positive pressure ventilation, babies who have meconium aspiration or meconium stained amniotic fluid, infants who have required resuscitation after birth, infants who are on positive pressure ventilation.